We have the cathode connection. We see Dr. Sharma, Dr. Kini, Dr. Kera, and of course Dr. Tang, the surgical associate.
All right. So are we ready now?
We're ready and anxious to do a special case.
Beautiful.
Dr.
Good.
Webb
And,
gave us a lot of examples of cases, so now everybody excited to see a real case.
So no, clearly, and thank to everyone, and more important, I just saw Dr. Marty Leon being there, so thankful, a special thanks to him to be part of this exciting symposium, and lot of knowledge, lot of theoretical, and now we get to the practical. As you already mentioned, with Dr. Tang, Kini, Khera, Sharma, and with fellow Amit Huda, and of course we on the echo, we have STEM as well as our another attending, Malcolm, and anesthesia, Dr. Benjamin Salter. With that note, we are ready to start this case presentation of case number 1. Very interesting case, 79-year-old, class 3 heart failure symptom. Patient has 25 millimeter Magna Ease surgical valve in 2010 and now has developed valve prosthetic stenosis, more stenosis than regurgitation. And of course, as a part, we did the cath today, which is non-obstructive CAD. These are the echo, but I think better we should show the live echo by STEM.
Yes,
STEM, you want to show the live echo right now?
Yes, absolutely.
Yeah.
Good morning. I have Dr. Anastasius in my left, who is our new imaging attending and a rising start in structural imaging. This is a 4-chamber view, normal LV function. And you can see a little bit dilated RV with mild decreased function.
Okay.
Again, this RV, little bit dilated right atrium. This is the velocity for the tricuspid regurgitation, a PA pressure about 30 to 35. This is a focus view of the aortic valve. As you can see, very degenerative, thickened, calcified, decreased mobility of the prosthetic aortic valve. This is with color, minimal aortic regurgitation, mostly severe stenosis. This is the gastric views, minimal aortic regurgitation again. And the velocity we got here is 4.9 centimeters per second, peak gradient 98, mean gradient 53, aortic valve area, but the continuity equation 0.5 centimeters square, severe aortic stenosis with acceleration time of 129 in case somebody is thinking about patient mismatch.
Okay.
Thank you very much.
Beautiful. Okay, we continue our presentation with the echo part has been done. So let's just go to individual work done. PE already have been shown. So CTA. So I'll ask Gilbert to make a comment on the aortic annulus on the findings of the outflow tract.
Yeah, so this is a 25 millimeter Magna Ease. So on CT, the ID is a little bit on the smaller side, around 23, 24, LVOT is bigger. Next slide. So, but the very big root, actually, the patient had originally a bicuspid aortic valve, so that explains why the sinuses and the STJ are so large. Next slide. And you can see the coronary height is well above the top of the valve, and we actually can show that on the aortogram we did here. So there's no risk of coronary obstruction at all in terms of valve in valve. Next slide. And Sahil, you want to mention about your access?
Access is relatively straightforward here. Big vessels, more than 5.5, not much.
And you're using a new device, right? For the closure potentially?
And then we are going to use a new Manta closure device in the end. And of course, Sentinel
Was
placed already in this particular case, and that's what we try to do. I know there have been an issue, which case you use Sentinel. Hopefully there will be a discussion later in our here that we try to use in every case, not selective, but it turns out to be only 50% gets it for various reasons. So this is the plan, 25 millimeter Magna with a pericardial sutured inside the stent. And then we have the valve-in-valve positioning with the Sapien 26 millimeter. But we fracture this with a 26 millimeter true balloon. So that is where the plan is. We are all ready now. We have crossed already. You want to show the aortogram, Anu? And then we can take the opinion.
Let me ask Dr. Bapat, who is a surgeon in the panel and of course the very much involved with the valve-in-valve, very useful app, which we already showed regarding the selection. Some comments regarding the rather, I don't know, small size of this initial valve and the nuances of this type of valve, perhaps, for our audience, Dr. Bapat.
So he's 79, so this is a very appropriate treatment, I would say. Valve-in-valve sounds good. You can see that the true ID was 23. And that's the reason we recommend 26S3. Fracturing will allow this valve to, the S3 to expand fully and give the best benefit. These valves we classify as valves with a metal band, and that's what is going to fracture, while polymer valves are a bit different in terms of fracture. The other thing is the fracture pressure in these valves seems to be pretty high, but the recoil tends to be less.
Good.
Okay,
Anu, you
great.
want to say what you're going to do with the surgical, the syringe point of view in this case?
And-
So essentially, we have the balloon across the valve now, so I'll inflate with the syringe and then go with the indeflator to really crack it. So I think it'll be a long pacing run. Anesthesia is all ready for resuscitation if it's necessary, and we are ready with the valve. Likely there will be severe AI when we do that.
You ready?
So
Just,
ready, guys?
yeah. Okay, just Vinny pointed out that you need a very high pressure. So that is what we have done. And so we are thankful to your app of this valve in valve. It made everybody's life so easy. Just like many apps Anu had made, this valve in valve app has
Empty
been
this
so
and then
helpful.
empty this
Okay,
as much and then
we are ready now with the,
I think one of the issues is
188.
whether you fracture before or after putting the valve, right? So I think we should discuss that, and it will be great to know how the team decided to fracture first rather than later.
Okay, we're expanding now and then going to the indeflator.
Yeah.
What pressure is that?
yeah,
Keep going, keep going. Okay.
indiflator pressure.
How high was that pressure?
What, 8?
Means usually in our experience as well as bench testing, it's something between
Off.
16 to
Off
18.
pacer, back up, third,
back up.
fifth, 60, 60.
Color, please.
20 actually.
Color.
20, wow.
Okay,
Okay,
go, let's go.
we should be ready with the valve. Yeah. You will
Valve.
resuscitation.
Color, please.
Negative, negative, negative.
Yeah,
So
so
before-
question will be that do a before versus after, yeah.
Before or after?
Pacer 80?
Raj? Would they having more
You're ready?
metal
Negative.
there make it harder to break?
Watch the
That's a
wire.
question always.
Yeah.
Yeah, but I think once again, I think a
Give me the
lot
valve,
of us
please.
feel better about having a
Guy,
valve
why?
in place, right? I think there is
Valve.
less chance of instability, and occasionally these valve leaflets might actually tear and the patient might become hemodynamically unstable.
sure,
And of
but-
course, there's a downside that you may be damaging the
Documentation.
leaflets of the
Okay,
new
good.
valve.
Okay, good. Yeah.
Okay. Orientation confirmed.
How do you judge for sure if the cracking worked or worked partially or didn't work? Vinny?
So there are two indicators. One is drop in pressure, which is more reliable than seeing the fracture itself. But we do watch the waist of the balloon, and if it suddenly gives way. Our strategy has been slightly different. We do fracture before, then we implant the device, and then we use the same balloon to post-dilate because now it's at lower pressure. And what we have seen on bench testing, which will be soon published
Okay,
as
good.
well,
What view do you
that
want to go to?
the recoil is less if you use that strategy.
So
No, it's
essentially
okay.
you're saying
You're saying
that
this, we don't change
do
the
a
view,
lot
please.
of pre, but
Okay,
also
good.
do
Okay,
a
let's
somewhat
go.
of a post.
Okay, no. Let's go.
Any other views
Okay,
from
go,
the panel regarding the
Let's start
pre,
it.
post, or preferences, or
Go
even the
slow.
choice
No,
of the
that's
new
okay.
valve? They're
Go slow on the replay.
putting an
Slow on
balloon
slow,
expandable
slow.
versus self-expanding TAVR valve
All the way.
in this case.
Excellent.
Would there be a choice here, Raj?
I think it's a good choice. I think if it was a smaller valve, you could have made a bigger argument or a stronger argument for a supraannular valve. But I think here there is plenty of room around, and maybe, if this patient yet needs another valve, I think this
Yeah,
patient
get
could
more
still
valves,
have
severely
yet
decrease the
another
function.
TAVR in the
And
future.
RV
So I think
function.
it's
Pacer 80,
it's a
pacer 80.
reasonably good choice.
Well, we're pacing at 80. Let's resuscitation. Dr. Herman, any views from you regarding
position of the valve.
the processes
Leaflets
of
open, no
pre-post and
Yeah.
choice of valve?
I generally try to post-dilate sapien
we take the wire
valves
out?
to
You can worry
fracture,
about
and
AI.
I pre-dilate
Okay.
evolute valves to fracture, because I worry a little bit more about damaging the leaflets with fracturing an evolute valve.
Okay.
Because of the
Pressure coming up.
It's
size mismatch.
getting better. It's getting
Yeah.
better.
And in terms of choice of valve, I think valve in valve is a sort of an extreme example in many patients of
Getting
the
better?
small
Back to
annulus
normal?
problem. So the best hemodynamics are going to be with the self-expanding
Okay,
valves.
back up. Can you slow
But
down
there are
the
many
pace?
other considerations, such as coronary access and future
Okay,
valves and all
come
of
down
that.
to 50.
We may have to
I
post-dilate
see
with
there
the
is a little bit of a
same-
waste in the 26 valve here underneath
AI?
at the ventricular side. certainly seems to be larger
Watch the wire,
than
watch
the
the wire.
waste.
Yeah, sure.
So you still have some waste in there. So
Yeah.
would this be a case of doing a post deal as well?
measure velocity.
Here that you were
Yep.
saying, Vinny and Howard?
We'll do it anyway.
Good.
We'll do
I
the
think you've
same
already
balloon,
fractured
we
the
go back
valve,
again.
so I don't think there's that much
Yeah.
advantage to another inflation. I think you have a slightly oversized 26 valve for that internal diameter, so I don't think it's going to get much better than this.
We need to get a pressure down, but I think we should do fracture
so-
once a moderate pressure, not
There
very
are some
high.
new concepts coming in. So what we have done in bench testing of this valve was we kind of defined what is
Hold on
known
one
as
second.
recoil
Everybody
index.
same
So
balloon.
think about it that
No,
you
Howie Herman said
dilate it
no.
with a 25 balloon. The Sapien or Evolut R, which whatever you implant, should try and reach that 25
Case at
ID.
110.
And maybe post dilatation helps a lot to achieve it if the waste was severe.
Okay, let's get the echo. So
Alain,
we'll get the
any
guidance
comment from
echo.
Professor
Yeah.
Cribier, please?
Okay, Stem, what is the echo?
Yes,
show?
well,
The
in
function is
in our
normal.
practice, in this case of
The aortic
Berlin
valve is in
valve,
good position. There
with
is
an
no
internal diameter of
minimal
24
aortic
millimeter, I
position.
think that we would
measure the
implant the
velocity,
valve
it's
without
about 2 meters per
pre-dilatation,
second.
without
Measure the velocity
fracturing
a minute
anything,
more.
doing
But
the
there
less
is
possible
no
things
AI
on the
at that
valve, because there is a risk, an increased risk of stroke, if you manipulate many things in a valve process. So I think we would have come with a Sapien, for sure, a 26 millimeter valve, for sure. We would have done that without general anesthesia and without transesophageal echo, and we would not have pre-dilate this valve, and we try to limit the balloon inflation in this valve for the issue of stroke. That's all.
A minimalistic approach here from France, Professor Cribier, just go in with a 26 Sapien, dilate it up, get out real quick. Dr. David Hood, any views from Canada? Lower button.
What if we check the gradient? What if we check the gradient? If the gradient less than 20 or 10, you leave it and do nothing more. That's
Where
the
is Dr.
question.
Anastasius to tell us the gradient right now? We didn't hear that because there was an overlap of voices.
Okay. Yeah. What is the gradient on the echo now?
But the echo, the velocity is 2, so it's a P gradient of 16.
16, 1, 6.
A mean of 7. Mean of
Minimal.
7
Mean of
Minimal
7.
by
gradient.
echo.
Minimum, yeah.
So I think this has just been an amazing morning. I'm still in shock from the presentation. The top 10, and then this wonderful team does a beautiful valve and valve. My goodness. But what I would say is we would put in a 26. We would do careful hemodynamics, invasive echo, and then if needed, we would fracture. And I think to Vinny's point and Raj,
PVC,
others,
why?
we're looking for that fall in pressure. That's crucial.
Very hyperdynamic.
And that would be the
ventricles.
strategy for us.
All right, we have
Jonathan.
another option for a semi-minimalistic approach. However, we have some questions from the
The
app.
audience,
Let's see.
I always want to make sure that the audience knows that we're looking for questions. You can send them in, and you guys call the 25 millimeter valve a small valve. Can you call a 25 millimeter valve a small valve, really? That's the question. Who wants to answer that?
No,
Vinny?
26.
So I think one of the things we have to remember that it's relatively big and relatively small based on patient's BSA. So
Pacemaker
that's one of the
80.
important things we always look at and then decide whether it's small or large.
If you look at the
Pacemaker at
size of
80.
the aortic root, it's quite big, right? I think it's very likely that if this patient were to undergo TAVR today, you would most likely be putting in a
Pacemaker
29
to back up.
millimeter valve.
Nice.
80 is good.
So it's a relative answer then. 25 is a valve that the way as we saw, the 25 is the outer diameter. The inner diameter was 23, so reflecting more on that. And also the mismatch we saw from the root, as well as the aspect of the BMI or BSA that Dr. Bapat brought up. But the fact that the gradient went down to 6
No, but
is
LV
a
also
tremendous
came to
result. Mean gradient of 6 and 0 gradient, maybe even 2 gradient by the catheterization. Actually, the gradient very much correlates. About a gradient of 2 or 4, mean gradient of 4 by catheterization. That's great. You made that a 300 scale or
You
something.
ready for Menta?
Oh, we have to give a
Great.
mean and everything.
Okay. So the question comes is, basically, I think if everybody agrees, looks great. The gradient is in single digits. That's how we do. And I know Vinny said that some data coming that you post-dilate again, even with a good hemodynamics. Will he do it? Raj and Vinny and of course Dr. Leon, let's take opinion from all three of them. Whosoever, two of them, whatever they will say, we'll do it. We are ready with that.
I think if
Two
your
out of three.
gradients
Let's
are
take their
below
opinion.
10, you probably don't need to. But what
Okay.
we are saying is if it's a polymer valve, say Mosaic, Epic, all those, the recoil because of the polymer is very high. And those are the valves where we tend to definitely
not
do
the polymer
post-dilation. And it's at lower pressure now, so it doesn't affect the valve.
I'll be content with leaving this now and not doing any post-dilatation.
I just
Okay,
want to make
Marty?
the point about gradients, that low gradients right after the procedure are helpful. They tell you something about how the valve function is and whether you fractured the valve successfully. But we know from numerous data sets now, one from our hospital, one from Amir Abbas, that the gradients go up quite a bit by day one. They're usually 2 to 3-fold higher, both because of flow characteristics and also recoil of the valves. They adapt over the first day and become somewhat smaller, both valves. So you just have to keep that caveat in mind when you think about the low gradient after the procedure. It's helpful, but it's not perfect.
Well, that's a matter
Okay.
also of the discrepancy we called, because there was a discussion regarding the discrepancy of the gradients of the surgical valves, and no surgical valve is measured in any way right after implantation. It's always measured a few days, if not weeks afterwards. So no wonder there was some discrepancy with what you measured here moments after you implant the valve. And no question, this is a great result though, and I think they're ready to apply the closure now, safe closure. Let's have the camera focus a little bit more to the area
So-
of the closure,
yeah,
so we can show
We are trying to
we
do
can
some
see
new
clearly what's
with the
happening.
Manta device plug closure. Yeah.
Yeah,
Maybe
we
you
no
can talk a
longer
little
need the
bit more,
hemodynamics, please, from the screen. Just make the
Take the hemodynamics away.
operators very big, and that's right. You have to focus on the device, though, please.
Photo off, just focus on the drawing.
Yeah, Sentinel. No, let the Sentinel
Getting ready
retrieve
for
the
Sentinel. Getting ready for the Sentinel retrieval.
Retrieval. Yep, done.
Protamine, please. 40. Thank you.
Good.
Excellent.
Yeah, tell us a little more about the device you are going to use, Sahil.
Yeah,
Keep
so
keep going also.
no, we have to wait for him
Okay.
to give the
Yeah.
protamine. So the Manta has been here for quite some time now. There's been a lot of studies about it, especially the recent choice closure, which was not very good in my opinion. But I
As a
think
study
it's
or no good
a
results?
good. Well, I would say the
Both.
results weren't as we were expecting, and. Oh, my sheet is.
But and what is
So
our experience
anyhow,
with this device?
please
Tell
split
us.
the screen and show us fluoro now.
Yeah.
Half the screen, half the
show the
screen
fluoro.
operator, half the what you have, and half the screen
me a
fluoro.
wire.
Okay. Anyhow, you can see that first of all, Dr. Chiara is inserting not only the wire but also the dilator inside the sheath in order to remove it more carefully. So you got to
You can
insert
see
the
that
wire.
the valve has little. If everyone can see, the sheath is a little split here.
Okay. Well, why don't you retract
new
it and
supercut.
marry it on the way out?
Yeah, pull back a little bit.
You can
sheath.
marry it by advancing the dilator. You can also marry it by retracting the sheath.
Supracore.
Okay. We're going with the supracore wire. Keep talking what you're planning to do. What has happened here?
Yeah, so this device is actually a biomechanical closure device. And the beauty of this device is it has an anchor, and the anchor, arteriotomy, and the collagen. So it forms a sandwich. And that's why it's not really a plug-based device. It's more like an anchor sandwich device. I think it has utility in large bore access. You just have to be very careful with the selection of the cases you have. So we tend to use it for patients who have, can I get light, please?
Yeah,
the lights
perhaps
on
you
more
can
patients
show
who have-
while you explain this. Why don't you replay the femoral angiogram so we understand
Yeah,
and
can we
remember
see the
what it
femoral,
was? So we can take a look at the femoral angiogram so this way you can understand the selection of appropriateness for this device. First of all, there was ultrasound guided access, very important, and you can see where it entered.
Yeah.
in the common
so this is an
femoral.
RAO view. You
Common
have to make
femoral.
sure it's in the common femoral. It's away from any calcification. As you can see, there's calcification on the medial wall, on the lower side of your entry stick.
Very
we
important.
also
Stay
wanna
away
make
from the
sure that
calcium.
you're-
Ultrasound access,
That
stay
is
away
true.
from the calcium. Very important. And safe removal of the sheath over a wire or supercore wire you're using now. Is it what you always use for this device?
Yeah, for my go-to wire is actually Supracore.
Which is
for-
there now.
Yeah.
So-
And what has been our experience using? How many cases you have done?
So
using?
we've done 15 Manta cases. Luckily, we've had not the rate of complications that was recently reported. So as you can see, we are putting the sheath inside now.
Always important
Manta
for a case selection is very important. The absence of calcification at the
Yeah, so more than
insertion
6
point is
millimeter
very important.
vessel, not very tortuous. You want to make sure there's not much calcium. Your entry point has to be anterior. And I think just good femoral access practices.
Right.
So I don't know if others can comment on their experience with Manta.
And,
Okay,
and
you
you
show
do
us
have
first
to
here
measure the
what you're
depth
doing, yeah.
of the artery, right? So there is a measure stick
We did,
that you
yeah.
use to measure how deep the artery is.
So let's see where
Right,
we
the
are now.
deep- yeah.
You're in-
So
what
we
are
have
you
a clip.
inserting now? You inserted the device.
is 281.
Good. Okay.
We want to make sure.
So Raj, what is the depth which you are looking for to use the Manta?
You measure it, and then based on that, you actually deploy it, right? So I mean,
Yeah, so
it's
we
been a
measured
while since we
5.
used it. We used it in about 50 cases, about when it first came out. But it's been a while. But I recall that's an important part of this. So you cannot
can
just
see it,
use it
can we-
post procedure unless you know
Can we
the
zoom
depth
here?
of the artery.
So I think that's a
You
great
can
point,
see-
Raj. You have
Okay.
So
Take this
the
out.
closure looks pretty good here,
Yeah.
though we have to confirm that there's actually no bleeding. So we leave the wire in. I do a quick angiogram before taking your main wire in. Gentle cut there.
So we did the Safe Manta
So it looks
study,
pretty
and
good
as
there.
Raj
You
said,
have
it's
good
crucial to
distal
get
flow.
that puncture depth locator at the beginning. And we're actually going to announce a 7-center study called Ultra Manta, where we're going to use direct visualization with the ultrasound. Because I think the advantage with this device is singular operator with your left hand on ultrasound, you can actually watch the foot plate come up and make contact. And
So
not
we're
only
all
that would
done
be
here.
fabulous
That's it?
for
That's it?
this procedure, but
Wow.
other large bore
see.
procedures done emergently, you could then hopefully get an expanded indication, and we're hopeful
That
that
is
trial
great.
will lead to that.
And what
But
a
this is
great
beautiful.
result we got over here. Let me also clarify what a further comment in the app, very important to hear, is that there's another aspect when one commenting on a small or a non-small valve, a mismatch essentially, you have to do a little fact-finding. You have to go back in the original valve implantation and try to look at the original gradients after that valve. That's very important. If the gradients were rather low, and if there is a long time since that implantation, that valve clearly not functionally small. And we have to acknowledge that. No matter what other measurement is, that's, I would say, a more clinically driven criterion for the small or non-small of the valve. Very well stated in the app comment. And we definitely thank our senior surgeon, Dr. Paul Stelzer, professor of surgery at Mount Sinai Heart, to point this out to us. Very important. Not
Beautiful.
only our measurements, also
right.
do fact-finding. Well, many congratulations to the Cath Lab team, Dr. Sharma, Dr. Kinney, Dr. Tang, Dr. Kera, Dr. Huda, Dr. Lerakis, and Dr. Anastasius, as well as the anesthesia team.
And Dr.
Congratulations.
Slater. Good. And now you have a quick break, exhibit break, and then you start the lectures. We'll be ready for the second case, which is
We
the smart
started-
trial case.
Absolutely. And thanks to all the nurses and technologists in the Cath Lab team as well.